I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University in Canada, and I'm so honored to have with me Dr. Birgit Vogel from the Icahn School of Medicine at Mount Sinai, who is here to discuss the Lancet Women and Cardiovascular Disease Commission Reducing the Global Burden of Disease report. Welcome, Dr. Vogel.
Thank you so much for the invitation. I'm most happy and also honored to be here on behalf of all the commissioners that contributed to the report.
Absolutely, and we should really start off by acknowledging them and acknowledging Dr. Roxana Miran, who's the senior author on this work. I would love to ask you how you got involved in this work and what the rationale was behind it.
So the whole process actually started already more than 3 years ago, where at that time I was working as a postdoctoral research fellow with Dr. Miran. And it was the Lancet that approached her with the idea to do a commission. So there are many Lancet commissions on several topics, and they thought it was about time to do a commission on cardiovascular disease in women, and we couldn't agree more. And so at that time, we started the whole process because cardiovascular disease is still the #1 cause of mortality in women. And even though there have been many improvements in awareness and also a decrease in the overall cardiovascular mortality over, I would say, 30 years, in more recent years or in the last decade, that decrease in cardiovascular mortality really slowed down and stagnated. So the trend is not going now in the right direction. And that's why we think it was most important to bring the focus to this topic and understand why and how we can approach this issue.
Tell us about the aims of the commission that drove the work.
So it was to summarize the current evidence that we have on cardiovascular disease in women, but most importantly, to identify the knowledge gaps and identify overall gaps in treatment, in prevention, but also access to care in women compared to men.
Okay. And this was a global commission that involved healthcare delivery and outcomes among women with cardiovascular disease in high, middle, and low-income countries. Can you tell us a little bit about how disease varies across income levels across the world?
It was very important for us to have commissioners from all over the world so that we really have people that know what they are talking about, because we wanted to go in the different regions of the world, in different demographic levels. And that's why in the end we had 17 commissioners from 11 different countries. And so it was very interesting and to get to know about what does cardiovascular disease mean to women from different parts of the world, but also from different socioeconomic backgrounds. There is data that in regions that have low socio-demographic index, that's from the Global Burden of Disease study, the highest cardiovascular mortality actually shifts from men to women. So it seems like, and that's also confirmed by other data, that socioeconomic and cultural factors might affect women more than men. And that's a very important aspect that we wanted to highlight in our commission.
Okay. So you found that there was higher cardiovascular disease mortality in women in socially deprived regions. What were the causes of these cardiovascular deaths? Do you have etiologies that you teased out as the causes among the very many causes of cardiovascular death?
I mean, the most common cause is ischemic heart disease, and that applies to all the regions in the world. However, more granular data is really missing, and especially in those regions that have low socioeconomic index. And so the data that is submitted to the Global Burden of Disease database is really varies a lot. So the quality of the data in some regions is really limited. So that's also one of our recommendations, that we get more data from those regions, and especially quality data, and if possible, standardized data, so that we can compare it between the regions and can understand what are the regional differences.
What are some reasons you think may underpin this difference that we see in low socioeconomic regions?
So some of those regions are the role of the woman in the society is really impacted by social and cultural or factors, I must say. And so women have limited access to education. They have mostly caregiver responsibilities that might hold them back to actually take care of themselves. And it's not only because it's a burden on their time, it's also, and that really stuck to me when I read about that in some regions, it might be considered a selfish act to actually take care of themselves. And then mobility might be limited. And so a lot of, and here we are at gender differences, not really sex differences, because we really have to make a distinction between those. But here there are gender aspects that might contribute to the worse outcome in women compared to men.
Right. And there's also a cost to healthcare in some regions in the world. So when you don't have economic power because you don't earn a living, you might have less freedom to make choices for your health. There's also the issue of representation in research, both a gender issue or a sex issue, and also a regional issue, because there are vast areas of the world in which people, both men and women, aren't represented in research and clinical trials. So as you point out, there's a paucity of data to understand some of these determinants of health, but one can expect that they are multifaceted and multifactorial. What do you think some strategies are to close these gaps to improve health outcomes for women in low and middle income countries?
So as you said, it's a very important point that the data is missing or the evidence is limited. The most important factor is really funding. So funding has to be directed to those regions. Healthcare coverage is a problem, especially in women. We learned that from one of our commissioners, Professor Sulke, that told us that in Africa, a majority of women do not have healthcare coverage, but we don't even have to go that far here in the United States. Especially minority populations are often affected by the lack of healthcare coverage. So that's one thing. And then also, I don't want to limit this only to regions, but it's really communities. And those communities are also in the high income countries that we should not forget about. And it's the same thing. We have to enable those communities to get healthy food. And I think the most important part is to start at a very early age with education. So to educate people what is healthy for them, but then also give them the opportunities to live according to those benefits.
Right. So there are higher level factors like policy when it comes to education, healthcare, but also built environment, walkability, perhaps pollution, public health and prevention. But what are some of the things at the healthcare institution level that could potentially be implemented? I find that even in high-income countries and well-resourced countries such as ours, there's an under-recognition for some of the sex-specific risk factors for cardiovascular disease. And so our history-taking doesn't include peripartum, or hypertensive disorders of pregnancy, things like, hormonal menopause, polycystic ovarian syndrome. These issues must be even more pervasive in some of the lower and middle income countries of the world, I would imagine, but I'm not sure if this is the case. Did you look at health system level quality of care and potential gaps?
Unfortunately, we do not have that granular data, but I agree. I would imagine too that those are things that are even problems in high-income countries, and awareness is really suboptimal still among healthcare providers and among women. So especially young women are often considered not at risk for cardiovascular disease at all. And so I think that is another target population for us to identify, even though it's true that cardiovascular disease or women with cardiovascular disease present in general at a later time compared to men, there are still younger women that develop cardiovascular disease. And if they do, they have really worse outcome compared to a similarly aged man. So there's a need to identify those women. And I think it would be a good idea to work across different specialties, because women, even though they might not go for a cardiovascular disease prevention visit, they might go to a gynecologist, or if they are pregnant, then the obstetrician will see them. And so those are points where we should work together with those specialties to identify that those women and not miss them. So awareness amongst healthcare providers across different specialties is very important. But also here, the evidence base is still not ideal. So we know, and the evidence is absolutely increasing about those factors that you already mentioned, like pregnancy-related disorders, like diabetes, or hypertension during pregnancy, preterm delivery. There are many factors that we know that they contribute somehow, but we couldn't fully understand yet how they impact cardiovascular risk. And that's why it's also so difficult to include them in our risk models. So those mostly contain the classical risk factors that we know now for a long time, but even those might impact women differently than men. So risk estimation is in women, and especially in young women, is absolutely challenging. So that should be a target for us as well.
Recognizing risk factors, managing risk to prevent cardiovascular disease, and I would also say implementing treatments in women in a timely manner, because we see across cardiovascular diseases that women are less likely to receive timely interventions for MIs, device therapies, and even health services to support them once they have cardiovascular diagnoses, and also the implementation of evidence-informed medical therapies. Dosing of drugs sometimes lacks clarity because women aren't represented in clinical trials. So certainly multifactorial approaches are required to help bring women to their ideal cardiovascular health through disease and management. Tell me one key thing you learned through this work that you didn't know before you embarked on it, and what your advice is to other junior investigators such as yourself. You've trained at a great center with a wonderful mentor. Tell me some key things you've learned and what pearls you would pass on to other trainees.
So in the beginning, there were these commissioners from different fields in cardiology, and all of them had their topics assigned, and then they would send in their contributions, and they did not consider any word limits. So it was all a huge thing that I had to go through, and not only me, but really I read through all of it, and it was just one interesting thing to another. And I think the most interesting things were probably the regional parts. And unfortunately, we had to cut a lot. And hopefully they will be presented in another way. They will be also, we have a website for the commission, so those things will show up there, and I can only recommend to read through. And then obviously it just made me so angry how I don't know what other word I should use, but we might forget about the communities, the socially deprived communities. And when I was reading how so many aspects of gender differences that affect women's health, and especially cardiovascular disease, but overall women's health. And it just made me, I just thought we need to do something about it. So those are the things that really stuck to me. And even though I had some idea, because I'm working on this topic for many years now already, it wasn't that clear to me how important it is to identify those young women that are at risk for cardiovascular disease. So when we see them in wherever, unfortunately we don't see them in clinic, but so we have to find a way to see them and to identify them. That's also one important thing that I took away.
Right. And your tip for young investigators?
I think it's important to acknowledge sex and gender differences and the complexity of this topic, and to recognize in what detail of different life situations this could be rooted. So
I was going to say, I think a large step that each of us can do is to ensure that for any research we undertake and lead, that there's adequate representation of female patients in our cohorts, whether they be registries, clinical trials, or cohorts of any kind. I think that's one thing we can all do. I also think collaborating with other women investigators helps ensure that we're thinking of different gender and sex specific questions that need to be answered in our research.
It's actually the most important point, because to build the evidence base so that we can provide optimal care for women is in the responsibility of all of us. So to know how important it is to enroll women in clinical trials, to present data by sex, that should be a standard thing. And then a very important point that you just said, learn from each other, find out what is it that works, how can we convince to also for women participants to be okay with participating in a study, how can we tackle the barriers that might exist for them. So absolutely right. That's in our all responsibility as researchers to make sure that we improve in that aspect.
Wonderful. Well, thank you so much for your time this afternoon. It was such a pleasure getting to know you, and my unique, distinct honor in discussing a subject that's close to my heart and also some of the basis of my research. So lovely to get with you. I hope we have a chance to collaborate sometime.
Thank you so much. It was a pleasure and an honor to talk to you.